Hello, I'm Allison Zielinski. I'm an instructor of clinical medicine and cardiology at Northwestern and the co-director of the sports cardiology program. And today I'll be talking about the echocardiographic evaluation of athletes. I have no relevant disclosures. So there's a fair amount of debate about when to get an echo in terms of screening in athletes. And for screening purposes, it's not currently recommended. There's actually also a fair amount of debate about whether or not we should screen all athletes with EKG. But for echo, a few of the barriers are high cost, low yield of significantly clinically relevant abnormal findings. And if it's not done by experienced providers, it can lead to increased downstream testing and inappropriate restriction. So currently it's only performed in select groups of athletes under expert supervision. For instance, the NBA draft, they all get echoes and stress echoes. You also have to know what the limitations are of the modality. It's not ideal for imaging the right ventricle. It does not pick up channelopathies, help you evaluate for lung QT syndrome, and limited ability to evaluate anomalous coronary arteries. You can, if you're looking in the short axis view, sometimes see the ostia, but most labs and sonographers are not necessarily trained to do that. You would get an echo for screening if the athlete has a history of hypertrophic cardiomyopathy or bicuspid aortic valve in their family. Another instance where you would get an echo is if after evaluation of an abnormal EKG. The EKG guidelines are pretty good about directing you towards particular testing. Certain patterns you may want to get an MRI for further evaluation, particularly if there's a question of any right ventricular pathology, or if it may be suggestive of an area that may not be as well seen on echo. And then electrical abnormalities or other abnormalities you usually just want to rule out structural heart disease. And then we'll always get an echo for evaluation of symptoms or abnormal findings on cardiac exam. So as cardiologists, we are always trying to accurately diagnose and treat conditions that may put our patients at increased risk of sudden cardiac death. And when we look at sudden cardiac death in athletes in age under 35, most often it's due to genetic conditions, hypertrophic cardiomyopathy, coronary artery anomalies, some acquired conditions like myocarditis, but in age over 35, more often due to coronary artery disease. The incidence estimates vary. It's approximately 1 in 200,000 in high school athletes and marathon and half marathon runners, higher in NCAA athletes, 1 in 50,000. But we know there are also higher risk populations. Men are at 9 times greater risk than women, African Americans, and basketball athletes. And in a study done by Kim Harmon on 10 years of NCAA data, the incidence of sudden cardiac death in a Division I male athlete, basketball player, over his 4-year career was 1 in 1,300. And actually the most common cause of sudden cardiac death in this population was autopsy-negative sudden cardiac death. So no clear structural abnormalities on autopsy. So it just shows that we have a lot to learn about what these risk factors are. So to know what is abnormal, you have to know what's normal for cardiac remodeling. And it encompasses structural, electrical, and autonomic adaptations. The degree of remodeling depends on factors inherent to the athlete, like gender, body surface area, age, and race, as well as the type of sport, dose, duration, and intensity. And we think it takes at least 4 hours a week for months to years in order to affect some of these changes. So we think of the typical pattern in primarily static exercise being concentric hypertrophy of the left ventricle with little change to the right side or atria, normal ejection fraction, normal to low normal diastolic function. And then with primarily dynamic exercise, you see an eccentric hypertrophy pattern with balanced 4-chamber enlargement, normal to low normal ejection fraction, and normal diastology. This is the chart that classifies the sports based on their hemodynamic demands. The dynamic components on the x-axis and the static component on the y-axis. This is also the chart that's used for knowing what sports are safe for competition for athletes with certain pathologies. So 1A tend to be kind of lower risk sports. And then it's generally used as a rough guide since you may have an athlete that plays more than one sport, or even within a particular sport, you'll have different demands based on where, if it's a team sport, might vary. So we know that the LV remodeling really does depend heavily on the sport. This is from Italian data. In the gray bars, you can see that some of these sports that have the highest static and dynamic components show the greatest degree of remodeling, both in cavity size and wall thickness, and then primarily static sports like weightlifting, wrestling, mostly just LV hypertrophy without too much change to the cavity size. And we know that also athletes tend to have cardiac dimensions that will fall outside the bounds of normal, or what's considered normal by ASC criteria. And this is a large population of athletes from Italy from different sports, and 14% of the male athletes had LV and diastolic dimension over 6 centimeters. And this is largely determined by body size, type of sport, and gender. And then male athletes also pretty rarely only have hypertrophy over 12 millimeters, only 2%. And women, even though they do show remodeling from baseline prior to training, the cardiac dimensions, including cavity dimensions and wall thickness, rarely fall outside the bounds of normal. But we do know that Black athletes also remodel more than white athletes, even within the same sport. And this was a group of 300 self-identified African and Afro-Caribbean athletes. You can see that 18% of the male athletes had LV wall thickness of 13 millimeters or above, compared to 4% of white athletes. And even female athletes, 3% had LV wall thickness over 11 millimeters. And then the other clinical conundrum sometimes is evaluation of the right ventricle. So we expect some remodeling, but the cutoffs for what's considered normal is not always particularly helpful to know when at what point you should suspect that it's potentially pathologic remodeling, and we're always trying to distinguish that from ARVC, particularly when investigating EKG abnormalities. And there's also a question of whether or not exercise can cause something that looks like ARVC, with dilation and dysfunction and some fibrosis at the hinge points. And it's not entirely clear whether it's a pathology solely due to exercise or potentially exercise exacerbating some underlying predisposition. And we can see late gadolinium enhancement at the hinge points of the RV insertion, and still kind of unclear clinical significance. And then with echo, the right ventricle can be difficult to fully image. Often we get MRI to more definitively rule out pathology. Finally, the aortic root enlargement is not considered part of normal physiologic remodeling, and we know this from the NBA data. These are tall athletes with high body surface area, so we do see increase in dimensions with higher body surface area and height, but it does plateau at those highest levels. So anything above 4.1 centimeters is considered abnormal and should be investigated further and serially monitored. We'll go through some cases. This is a 21-year-old male college soccer player with a family history of hypertrophic cardiomyopathy in his father. He himself is asymptomatic. His EKG is normal for an athlete. His ejection fraction is normal, 67%. Septal wall thickness 1.3, posterior wall thickness 1.1 centimeter, with normal left atrial size and function of the right ventricle, with no SAM. So looking at the diastology, it's very normal. Septal E primes of 9 and a lateral E prime of 16 with a normal ratio. And the global longitudinal strain is normal at negative 18.8. So ultimately, this athlete, he also underwent an MRI, and he was not found to have any pathology. So when we're looking at So I would scratch that last part, that last thing about the athlete, and then I'm going to pause and then start over for this slide. So differentiating LV hypertrophy that's physiologic from early forms of hypertrophic cardiomyopathy can be challenging. And most of the data originally was based on, in discrimination, was based on hypertrophs that were sedentary. So these are some of the discriminating factors, and this is mostly in athletes with a kind of gray zone LV wall thickness, because over 15 millimeters is always abnormal. So if the LV hypertrophy is asymmetric, particularly if the LV cavity is also not enlarged, if the left atrium is enlarged without the LV being enlarged, abnormal diastology, late gadolinium enhancement, and then obviously family history or genetic mutations are going to kind of increase your level of suspicion. So this was a study that was done actually on athletic hypertrophic cardiomyopathy patients. They chose to compare them to sedentary hypertrophs and picked athletes and hypertrophs with kind of that moderate degree of hypertrophy, or any sort of in that gray zone, the 13 to 15 to 16 millimeters. But they found that, you know, a little bit contrary to the prior chart, that the athletic patients with hypertrophic cardiomyopathy had larger LV cavity dimensions and superior indices of diastolic function, with normal to supernormal VO2 max. So even if you find, even if you have an athlete that has sort of borderline findings, but those things are normal, it doesn't necessarily exclude hypertrophic cardiomyopathy if they have a significant exercise history. Now, most of these patients also did have really abnormal EKGs, but that's also partially due to the sample population, because they were referred from a tertiary referral center. But even the diastolic function, or the E to E ratio, was normal in all of these athletes. So case 2 is a 21-year-old male basketball player who presents with an abnormal screening EKG. These T waves are very abnormal, inferior and anterolateral deep T wave inversions. He has no symptoms, a normal exam, normal vital signs. So undergoes an echo, and it shows a mildly dilated left ventricle with mild concentric LVH. RV is dilated, mild biatrial enlargement. EF is mildly low at 48%, that's by 3D. The diastology, so is mitral septal E prime is 14, mitral lateral E prime 18, and the average EE ratio is normal. So that's on the plus side. It's kind of in the more normal range. And then the global longitudinal strain is on the lower side, mildly reduced, negative 15.6. So this athlete underwent a stress echo, and he did very well, 17 METs. He had completely normal augmentation of his left ventricle with exercise, hyperdynamic, and the global longitudinal strain also increased to negative 19.7. So this athlete was cleared to play, but he should have serial evaluations based on that abnormal EKG, just to make sure that that's not an early marker of pathology. So we know that athletes, particularly athletes with dilated LV cavity size and that high dynamic, high static sports like triathlon and cyclists, will not uncommonly have mildly reduced ejection fraction, or potentially slightly mild and low strain. The concept of just that it takes a little bit less deformation to affect the same stroke volume, since you have a larger LV cavity size at rest. You can see on the bottom left, this is a healthy male cyclist, just how much bigger his heart is. It's basically just a larger, more efficient pump. Strain in athletes is a little bit too large of a topic to talk about in my 15-minute talk, but obviously strain can be very helpful in a lot of different pathologies. If it's significantly low, under 15% for LV global longitudinal strain, or if the pattern is significantly abnormal, that can help, that should still be, could clue you into pathology. But there's a fair amount of heterogeneity in the studies about what happens with training. So the third case is a 32-year-old male endurance athlete. He has a normal LV cavity size, EF of 60%, and normal left atrium. The RA is mildly dilated, RV is dilated, his pulmonary pressure estimated is normal. So the annular dimension of the right ventricle is 4.7 centimeters. His EKG is normal for an athlete with just an incomplete right bundle branch block. Looks like first degree block as well. And his TAPSE is normal, RVS prime is normal, FAC. The free wall strain is kind of low normal. So the main kind of dilemmas when we're looking at the right ventricle, as I mentioned in the beginning, so it's a thinner walled structure that, in these high flow states, chronic kind of higher flow states, you can see a greater degree of remodeling compared to the left ventricle. You should not see disproportionate enlargement of the right ventricle, but since it's a little bit less resilient, we do see evidence of transient RV fatigue following ultra-endurance exercise that can correspond to biomarkers. And the degree of remodeling and the size really depends on the type of training, the duration of training, the pulmonary, the PSP, and the LV stroke volume. So because of these higher degree of flow, the upper limit of normal for our PSP in athletes 40 millimeters of mercury. But always low normal function and mildly reduced can be normal, but if it's more than that, it requires further investigation and should be in the absence of any regional wall motion abnormalities or aneurysm. And there should be normal contractile reserve and no significant symptoms. Similar to the LV, we know that athletes can often have dimensions that fall outside the bounds of normal and will meet just size criteria for ARVC. And this is, these are the 95th percentile cutoffs. This is how many athletes were above that range. Now, the other thing to look at is the ratio of the RV end diastolic dimension and LV end diastolic dimension in the apical kind of four-chamber view, comparing the diameter versus in the basal dimension. And the ratio of the RV to the LV should be less than 0.75 is normal. So this is a chart that shows some of the discriminating factors. So things that would lean more towards ARVC are that the RVOT is more dilated than just the basal dimension of the RV, an RV to LV ratio of over 0.9, any regional wall motion abnormalities, akinesia, aneurysms, bulging, reduced function of FAC under 32% or strain under 20%, or abnormal cardiac MRI findings. So I'll go through a quick case 4. This is some sort of timely case, 18-year-old male college baseball player who presents following having had COVID for return to play evaluation. He had a really mild case of COVID with a headache, no fevers, and no other significant symptoms. And then he had 2 negative tests since his illness. He has no cardiovascular symptoms, and he has nothing else concerning. He's been screened a couple of times, including at the beginning of the season prior to the COVID break. And his EKG shows more than 1 PVC. One of those is a fusion beat, but more than 1 PVC is considered abnormal and requires further investigation. Obviously here we're also kind of on heightened alert for evidence of myocarditis. So, and just to note, there aren't really any specific EKG findings for myocarditis. You can see T-wave inversions, or the main thing that we're on the lookout for would be something that would be predisposed to an arrhythmia, so also ectopy. So undergoes an echo, which is normal. He has normal LV wall thickness, wall motion, LV size, and the global longitudinal strain is normal, normal diastolic function, atria. And then as part of the evaluation for multiple PVCs, he has a exercise treadmill, which shows PVCs, isolated PVCs, but they don't abate with exercise. Usually kind of in the more benign active B will be suppressed during the stress test, but he didn't have any couplets, triplets, or NSVT. And then he also underwent a 24-hour Holter monitor, and it showed 4.7% PVCs with 4,700 PVCs. And the cutoff for sort of investigating further is 2,000 PVCs in 24 hours. So this is still kind of above that, but there was no VT. So the next step was a cardiac MRI. And it showed mildly dilated left ventricle and right ventricle with normal function, wall motion, and no like gadolinium enhancement or pericardial enhancement. So the assessment for evidence of myocarditis or pericarditis was negative. It did show this hypertrabeculation along the apical lateral and inferior walls and extreme apex. So they raised a concern for non-compaction cardiomyopathy, but it was only in one area, one area of the left ventricle. And then so requested an overread. That was a radiologist that read that. So requested an overread from the cardiac MRI cardiologist, and it came back. It was read as completely normal. So I have a couple points. One is just don't overlook the other things in the post-COVID evaluation. Don't have blinders on. But the other thing is that we can see hypertrabeculation in athletes, and it seems to be a fairly common phenomenon that should not be always labeled as non-compaction cardiomyopathy. And for non-compaction cardiomyopathy in the guidelines for competitive sports, it really hinges on whether or not they have clinically significant or complex ventricular arrhythmias or LV dysfunction, since there's such a wide range of spectrum of severity with that disease. So this athlete was ultimately cleared. He will be seen by an electrophysiologist, but there isn't anything else that's kind of come up that would necessarily restrict him. And this algorithm just came out a few days ago. It's an update to the one that's in the slides, but this is based on expert opinion and return to play for athletes after having had COVID. And a lot of it's just based on kind of experience so far, since we're all collecting data. But there was concern for cardiac involvement and myocarditis, and so there's a few small studies that have raised the question of whether this is something we need to worry about in a larger portion of athletes that have had a very mild disease. But on a widespread scale, it's kind of, it may be a little bit overkill to, sorry if we can cut that out too. I'm going to start this slide over. Pause. All right, so I can't end this lecture without talking about COVID again, as it's on everyone's minds. And it's been a particular question in the evaluation of athletes in return to sport and the risk of myocarditis. And there have been so many unknowns. We had initial data about hospitalized patients who were really nothing like the population of patients that we're seeing. But then a couple smaller studies like Ohio State, where there's a little bit disturbing findings of possible myocarditis in athletes that really had hardly any symptoms. So this algorithm was just published in JAMA Cardiology a few days ago as an update to a previously published expert guideline. It's a consensus, since we're all gathering data but don't have a lot of data. But it's a little bit more geared to the first decision point is did the athlete have a very mild case of COVID? If so, and they've already completed their isolation period, then and they have no cardiovascular symptoms, they don't necessarily need a full cardiac workup or clearance. If they had moderate symptoms, of COVID, then they should have some evaluation after their isolation period. And that would include EKG, high sensitivity troponin, and an echo. And if those are abnormal, then you undergo further evaluation. But any patient that had severe enough symptoms to be hospitalized should have a little bit more thorough evaluation with, it's good to get the troponin numbers or the troponins while they're in the hospital. And an echo or potentially an MRI. But then you would, if, obviously there are findings of myocarditis, they follow the guidelines for return to play for myocarditis. If no symptoms, and then they resume training, but then there are, if at any point they develop cardiovascular symptoms in their return to play, they should be evaluated. Cardiac MRIs are kind of our main tool for looking for evidence of edema or inflammation. I think there are a couple important points to note is that with the use of high sensitivity troponin, you can get troponin elevations even after hard workouts, not uncommon after, say, a marathon, but even a lesser degree of kind of intense exercise. So these should be measured at least 24 to 48 hours after exercise. So I would err towards 48 hours. And then they shouldn't be persistently elevated if it was just exercise. So if it's elevated, it should be checked multiple times. And then with cardiac MRI, I think one of the other questions is that, we're still trying to figure out what's normal in this population. And sometimes you may find a little bit of scar that you don't know if that was related to this COVID episode or it's old and irrelevant. So I think as we're learning more, everyone's gathering data, as I said, and I think as we all learn more about what's normal, it'll help us kind of stratify this risk a little bit more. But there are certain circumstances that if it really doesn't fit myocarditis, no symptoms, negative biomarkers, but you find a little something on an MRI, where you may just consider expedited testing instead of the full 3 to 6 month restriction. All right, so the take-home points. So these are so you should always match the degree of remodeling to the athlete, the sport, the dose, and intensity. So even if it looks like it's kind of normal for one thing, if it doesn't match up with their exercise history, then it could be a marker of pathology. Things that are not physiologic remodeling are more than a mildly reduced right or left ventricle function, LV wall thickness of more than 15 millimeters in men, or more than 12 millimeters in women, or asymmetric hypertrophy, regional wall motion abnormalities of the left or right ventricle, abnormal diastology, or greatly or significantly reduced global longitudinal strain under -15. And the right ventricle should not be dilated in isolation and should not have any aneurysms or late gadolinium enhancement. And then an aortic root of more than 4.1 centimeters is always considered abnormal. All right, that concludes my talk. Thank you very much.